Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Welcome to Cracking Cancer. I'm your host, Dr. Kyle Concannon. Today we are here talking about what is a pulmonary nodule and is my pulmonary nodule cancer? Joining me today to talk about this is Ashley Holt and Dr. Alex Dragnich. I'll let you both introduce yourselves, and we'll start with Ashley.
Hi, my name is Ashley. I'm 38 years old, and in September of 2024, I was diagnosed with stage 1 non-small cell lung cancer due to a ROS1 mutation, and that was all uncovered through a nodule in my lung.
Sharon, Alex.
I'm Dr. Alex Dragnich. I'm an advanced lung disease specialist and pulmonologist at Vanderbilt Medical Center in Nashville, Tennessee.
All right. Thanks for joining us, and an expert guru about all things pulmonary nodules, person I talk to when I have pulmonary nodule questions. So kicking us off here, Ashley, your whole story started with a pulmonary nodule. So I'd love to get your perspective as to how was your nodule found? Tell us the story there.
Yeah, so technically it started with a random lump on my chest wall. So the shortest way I can describe how my pulmonary nodule was found was an incidental finding. But as I was thinking about this podcast, I don't know if that's the right term because they found a mass on my chest wall, and that was found in a breast cancer center. And without making a long story short, they identified it wasn't breast tissue. They identified that it looked abnormal and it needed to be biopsied. So at that point, I was presented with the option of getting the biopsy in the breast cancer center. But I have a medical background, and I read the ultrasound, and it said it wouldn't be it would be a soft tissue mass. It was not breast. So I really pushed back, and I didn't want my biopsy in the breast cancer center. That ended up saving my life because several doctors said it was okay. They were fully qualified to do the biopsy in the breast cancer center. I actually went to get the biopsy in the breast cancer center. And I just lucked out. And the doctor that day, I was on the table getting ready to be biopsied. I made my plea again, and she agreed, called a sarcoma oncologist. And at that point, she said, yep, it makes way more sense for me to biopsy. But before I would biopsy, I want another image. I would like her to get a CT of her chest with contrast. And so I'm not sure if she did that because she wanted that image to get a better look at the chest wall mass, or because she was looking for a nodule in my lung. So obviously, if the CT of my chest was just to get a better image of that mass, then it was absolutely an incidental finding. But I don't know, or maybe she was looking to see if it had metastasized to my lung. I'm not really sure.
Sounds like either way, you were getting a workup for something different. You had this
100%.
chest wall mass, and then I would call that an incidental finding. They weren't expecting that to be there. And
From
then,
a patient perspective, it was the last thing I thought we were going to find. I was worried about this chest wall mass, and I had no idea there was something in my lung.
well, and then, so you had this CAT scan and they said you have a lung nodule. Okay. So, Alex, maybe we can pin over to you now. Tons of people are told every year you have a lung nodule. Like, what does that mean? What is a lung nodule?
To that question, a lung nodule can turn out to be a lot of different things, ultimately, when we look at it under a microscope. But when people usually hear that, it's usually in the context, just like Ashley said, of an X-ray, if it's a bigger nodule or a really dense nodule, or probably more commonly a CT scan, either obtained for a reason related to breathing symptoms or completely unrelated, related to other problems. When we look at when a radiologist or a lung doctor or an oncologist is looking at those images, when they see a lung nodule, it's really talking about a little grouping of tissue, a little ball of tissue that's a little bit more dense than it's supposed to be. The lung, you can kind of think of it like a really big sponge. And so a really big sponge with lots and lots of tiny little air sacs. And so the vast majority of it is supposed to be, filled with air. And so kind of big, or in this case, sometimes small, but cohesive groups of tissue are actually somewhat abnormal. And again, ultimately, those can be a lot of different things if we get to the point of taking a sample of it. But that's generally speaking what people or what the physicians are talking about when they say that there is a lung nodule.
So when they say you have a lung nodule, they're talking about a little area in the lung that's more dense than air. Do they usually mean really that's cancer or no?
Yeah, I think a great and actually very, very important question. No, there are a lot of different things that can cause lung nodules. And really, when we say or hear or see a report of a lung nodule, that's just telling us that there's something there that isn't normally supposed to be there. Now, one, that is not to say that, one of the first questions we ask is, could it be cancer? Because that is, probably one of the most important questions that we ask anytime we see a new nodule or one that's changing. But I broadly group it into three kind of causes. Either cancer, again, that we try and get a quick answer to, inflammation due to something that's related, completely unrelated to cancer, but maybe related to an autoimmune disease, or potentially even infection. And the last one, infection, can be really, really common depending on what part of the United States you're living in. And so, without going into too much, into the weeds there, if depending on the part of the country you're in, certain fungal infections or evidence of prior fungal infections can be really, really common.
So maybe not cancer, maybe it's just fungus in your lungs.
Yeah, and so to clarify, so that is a really, really when I tell patients that, it's they oftentimes have that reaction because you're telling me there's something growing in my lungs that's not supposed to be there. Depending on your following of pop culture, fungal infections have not been portrayed very, very positively in pop culture, but really, there's a particular, especially here in Tennessee, common fungal infection called histoplasma. When the body sees something that's not supposed to be there in the lung, the way that it often reacts to that is by walling it off, by kind of the immune system walling it off into a big ball. And then it just stays there in this kind of isolated little nodule or tennis ball until the body can get rid of it. Sometimes it just turns into an old scar.
So when you have the CAT scan or the X-ray, you see these signs that either it's something like a tumor that's more dense than air, this walled off infection that's more dense than air. When inflammation comes in, that's more dense than air. Are there certain signs on the X-ray or the CAT scan that are like, this is more likely to be cancer? Are there buzzwords that people should think about?
That's, there certainly are. But I'd say probably the most important two things when we look at those scans that help us increase our confidence ahead of time in saying that something may be high risk for cancer or low risk for cancer are the size and how it changes, the pattern of how it grows. Certainly, if it's a big nodule, that's always concerning, especially if it's the first time you've ever seen it, if first time that they've ever found it. If you're starting from a place where it's already pretty big, then we like to get an answer very quickly. If
Can I interrupt? What does big mean
Yeah.
to you?
Yeah, that's a great question. So anything over about, for ballpark, say about a centimeter.
Okay.
A centimeter we don't think of as pretty big, but when it comes to something that's not supposed to be there in the lung, a centimeter can be, pretty large. A nodule, something is a nodule if it goes up to about 3 centimeters. So that's still pretty small if we think about it,
Okay.
about that big. But depending on other features of the nodule and traits of the nodule, even something as small as 8 millimeters is kind of when we start thinking about, do we need to go straight to answering this question right away of what is this with a biopsy? But the other features, kind of the patterns of growth, cancers operate under what we call something called a doubling time, meaning that these are cells, these are things that have to grow, that have to expand, and so they need time to do that. And so if something is changing, steadily, consistently, and growing, that can be pretty concerning that we could be dealing with a cancer. But alternatively, it's somewhat double-edged there, in that if something is growing really quickly, very, very fast, then that actually may not be consistent with a cancer because it's just growing faster than the cancer could grow itself, and maybe more likely to be something like an infection or inflammation that can grow quite rapidly. Also, if it starts to grow larger, gets smaller, and then starts growing again, cancer really only has one mode in the absence of something that we're doing to treat it, and that mode is I'm going to try and grow. And so seeing it fluctuate like that, seeing it get bigger, get smaller, that can argue for or against, more against something being cancer. Now there are other, kind of nodule. There are other features of the nodules that can be more or less concerning. If little parts of them have little bits of calcium, so things that almost look like a little bit of bone on the CT scan, very bright, dense calcium, depending on that pattern of how that appears in the nodule, that can make cancer very much less likely or very much more likely. And then similarly, its shape. So if something is a really smooth, well, bordered just ball, that actually is a little uncommon for cancer because it has one mode and it's to grow, and it's whichever way is easiest. And that's usually not in something that's really smooth and organized like that. So oftentimes, if it grows almost looking like it has little roots spreading out from the center, that can be a feature that's a little bit more concerning. And then, another thing that we always keep in mind is probably, the most important part of this, which is the patient. And so certain features of the person, make cancer more or less likely. If they, have an extensive smoking history or exposure to tobacco smoke, depending on if they have had radiation for one reason or the other, or been exposed to that. Or if they have, a condition or medications that, what we call immunosuppress them or get in the way of their immune system, which is the body's own natural way of keeping cancers out of the body and in check if they're there.
Thanks for going into all that detail. So it sounds like there are a few mechanisms that you'll all look into, or a few features that you all look into to determine if something needs a biopsy right now, like the size, the shape, how it looks on the scan, risk factors. So it sounds like there is a complex decision making that goes on, and it's not that everyone who comes in with a nodule needs an immediate biopsy. Is that fair to say?
Exactly right. Exactly right. It really is. It's taken person to person and nodule to nodule about what that risk is, and kind of what the individualized plan should be of what to do and when to do it.
So Ashley, what did they do with you? They see this nodule. What were the thoughts?
Well, I can tell you on the CT scan, it was spiculated, it was lobulated, and it was 2.1 centimeters. And so they wanted to biopsy it right away. Now, had they found that without the abnormal chest wall mass, I'm not sure if it would have been as urgent, because the radiologist who read the CT scan suggested that I either be biopsied or they repeat the CT scan in 3 months. They also suggested a referral to a pulmonologist, but since I was already referred to the sarcoma oncologist, she wanted to biopsy it right away.
And Alex, Ashley, you had mentioned spiculated, lobulated. We haven't used those terms yet. Alex, what do those terms mean, and what do they mean in the context of this scan?
Yeah, no, I mean, actually, those are the perfect kind of words, of course, to describe, some concerning features of nodules. Spiculated, when we talk about that, that's kind of that almost growing roots. So spiculated is it's almost spikes on a wheel. So it's little protrusions, little pieces, kind of working their way, kind of trying to expand outwards from a central kind of circular nodule. And when something's called lobulated, that's almost as if if you could think of like a walnut. A walnut has it's almost like a central ball, but it has these bumps all over the outside of the walnut. And that's when we say something is lobulated, that's kind of what it looks like. Now, those little lobules can be small, like in the case of a walnut, or it may be that they can be really big, and it's just three big kind of bumps to it, that take that shape. And depending on again, whether that nodule is by itself and there's no other nodules around it, or if it's surrounded by a couple smaller nodules, that can actually be really telling too. Cancers don't usually, when they start growing outwards in that way, they don't usually break apart and grow right next to each other. They can, and they can move, but having little tiny nodules right next to it, though it would not be enough to tell us not to biopsy it. It can, give us a hint that maybe we're dealing with something else like an infection, namely speaking.
So, Ashley, it looks like you had a larger nodule, relatively. You had the spiculation, you had this amorphous feature that wasn't a perfect sphere, and had projections. And they said, monitor or biopsy, and sounds like they were recommending biopsy. Is that right?
Yes, and they also said likely malignant in the readout of that CT.
Did you see that before your medical team talked to you about it, or did they
Oh,
tell you
yes.
first?
No, you have a new test result on a Wednesday night at 5 p.m. when I had my children. Yeah.
Yeah. Tell me a little bit about what that was like. Not every pulmonary report will say nodule is likely malignant. Most won't say that. So to get that information when you were alone having to figure out what this might mean, what did that mean for you?
I mean, I'll try not to get emotional. It was one of the hardest things that has ever happened to me. Um, I I had gone through a couple of tests by that point, of my chest wall mass. I'm a relatively very healthy person. Um, so anytime I got test results, I was never opening them. Like, I mean, this was obviously like concerning, and they were worried that I could potentially have a cancer, but when you're that young, you just don't, your mind doesn't go there. So, like I mentioned, I have a medical background. I have a lot of physicians as friends and also in my family. And so not only did I immediately react negatively, but then I sent it to my brother-in-law, who's a radiation oncologist, and had my neighbor look at it. And like the way they responded to it just made me know this is not good. And then I still had to wait to talk to my doctor. I mean, the offices were all closed. I had never met her in person yet. She wanted me to get that CT prior to our visit.
Jeez. Well, thanks for sharing that. I feel like with how medical information is portrayed to patients nowadays, that's how a lot
Yeah.
of challenging test results do come through. And that's a balance we've talked about before, where the patient having the right to all of their information versus, having it go through a provider to maybe help interpret some of this. It's a balance that the medical community hasn't perfected. Um, I don't know that there is a perfect way to do this. Um, but back to the question at hand, they decided to biopsy your nodule, but there may be some patients who, have less concerning features on their nodules. So, Alex, you know, how does one monitor a lung nodule? You had mentioned that, Ashley, you said that they said you can do another scan in 3 months. Alex, you mentioned one of the concerning features of lung nodules might be that they're growing, which means you have to check them. So, what do we do?
Absolutely. So, I mentioned, sometimes we see these on X-rays, sometimes we see them on CT scans. It really has to be something a little bit more granular than an X-ray. An X-ray is a 50,000-foot view of the lung, whereas a CT scan is more like a 50-foot view, if not closer. And so, generally speaking, it's done by CT scans. The bulk of this is done by CT scans. And the timing and whether to go straight to a biopsy, as was in Ashley's case, or to monitor those nodules is highly dependent on kind of those risk factors, those features of the nodule, and again, most importantly, the patient that increase or decrease their risk of cancer. And so, I mentioned a little bit ago about the doubling time. So these cancers are cells that have to grow. And so depending on the features of a lung nodule, if it's higher risk, as was in Ashley's case, then we want to take a picture of it pretty quickly, because a big nodule does not, it doesn't take very long for a big nodule to show that it's, grown. And I say doubling time, we're not waiting necessarily until it's doubled, to be clear. But rather that enough time with that amount of cells, that big of a nodule, 3 months, is enough to be able to see a difference and reliably say, this is growing at a speed that is consistent with a cancer. It's staying stable, at least initially, so we can have a little bit more time and space to look at it over a longer period of time, or it's getting smaller and we think it's not a cancer. And so, that chiefly is determined by size and the risk factors. But that can be a tough thing to tell folks. Again, that we think that this is a concerning nodule, but we need to wait to take a look at it again rather than going in and answering the question right now. We are creatures who like answers right away, and so that can be a tough thing to grapple with. One thing that we have to always consider is that when we do these biopsies, these are procedures, these are things that require being able to find our way there to where that nodule is, reliably sample that nodule, that little spot where that nodule is. And we've come a long way in terms of having advanced technologies to be able to do this. But we talked a minute ago about something that was, counts as large as being greater than a centimeter, or actually greater than 8 millimeters, a larger nodule by some society guidelines there. And so if you think about that, that's a nodule that's, smaller than the width of your pinky nail, and something is as big as your lung. And so, when something is that small, there's a real risk that someone can have one of these procedures to try and biopsy the nodule, and we get false reassurance of a negative test. When in reality, it was just that the nodule was so small that we couldn't be sure we actually sampled it. And so, adding in that element of changing over time allows us not only to make sure that it's big enough that we can catch it and get a sample of it, but also that we think that the likelihood of cancer is high enough that we that the risk of putting people through these procedures, is outweighed by the likelihood of providing a benefit, of finding a cancer or finding a diagnosis, and being able to act on that quickly. Now, the other part of this is that I talked a little bit ago about cancer has one is a one-way street. It's I'm going to try and grow, and so the likelihood of cancer moving in someone when the nodule is very small, if someone has an intact what we call an intact immune system, is pretty low. And so patients have, most importantly, the ability for us to be very thoughtful and intentional about getting them these answers with a high amount of certainty, so we can reassure them one way or the other exactly what they're dealing with.
And when you say a tumor has a low likelihood of moving, do you mean that like when a nodule is a centimeter, even if it is cancer, it's probably not going to spread to other locations? Because that, I imagine, is someone's real concern.
That's a great question. And so that in large part depends on, it's a bit of a catch-22 because it depends on what it is exactly. But it also depends on, some of those kind of high risk features, the presence of those high risk features that we talked about. So, that decision about whether to wait that amount of time to get that added information of how it's growing, or whether to just go straight to a biopsy, is where kind of your healthcare team and specialists really provide their expertise in being able to bring that information all together and provide one clear recommendation.
Yeah, I know.
I hate to say it depends, but in a way, it slightly does, just based off the appearance.
Here we always say that if someone gives you too clear an answer, it's probably a lie. So the people who know what they're doing are always hedging.
That's a fair point.
Yeah. And from a oncologist perspective, I think of those lower risk lung nodules. If they do end up turning out to be a cancer, I think of their likelihood of spreading to be pretty low. That's why they were lower risk. And the things that were higher risk, that are higher likelihood of spreading to other parts of the body, those are the things we biopsy right away. So if we're already in this bucket of let's watch it, then we don't think of them as high risk. Now, that doesn't mean zero risk. But as you mentioned, there is a risks benefit ratio with the biopsy. What are some of the risks of getting a lung biopsy, and what does that process look like?
Yeah, no, that's a great question as well. So to start, there are a couple different ways, actually, I'll say a couple, but 3 or so different ways we can do these biopsies. And we are actively looking at which ways are better for which circumstances. But one of them, and Ashley, I don't know which of these options was how they proceeded in your case, but one of them can be through a bronchoscopy with a pulmonologist like myself, where we take a camera on a very long, flexible kind of tube, and take a look down in the lung, and using some other technologies, navigating a small little pair of forceps or a needle all the way out to where that nodule is, and take a small piece of it. The other more common way is, instead of going from the inside out, going from the outside in, and using a CT scanner to guide, similarly, a larger needle to where they can see the nodule on the CT scan and taking a sample. And so both of those come with different balance of risk. The CT scan, for either of them, there's a risk of causing a leak in the lung because it's something sharp in a something that's kind of like a big balloon. So causing a leak is possible. And
What do you mean when
there
you say
could,
causing a leak?
yeah, and so the lung, using that balloon analogy, if you had a water balloon and you were to take a really, really fine needle and just poke a little bit on the side of the water balloon. Now, in a very extreme version, you might say that it might pop, but it doesn't actually do that. What more likely it does is a small little stream of water starts to come out. And similarly, that can happen in the lung, but if that happens, over a long period of time, or the leak is bigger, sometimes people can have a hard time breathing because the air gets trapped outside of the lung, but inside of their chest. And so that, that can, when that happens, the lung just can't open all the way because there's this pocket of air, a balloon of air right there, preventing it from doing so, but also being in a place where your body can't actually get the benefit of that air. Now, the way I like to describe this to patients when I'm talking to them about bronchoscopies is that the lungs are actually a pretty, it's a beautiful organ, but it's a pretty simple one. It's kind of like an extension of our skin, just on the inside. If you think about it, it's all just an extension of our skin on the inside. It just has the added job of helping us breathe. But similarly, if you got a cut, if you poked yourself with something sharp on your hand, your skin would form a scab, and it would stop the leak. And the lungs do something incredibly similar, just the same way. So most of the time, even though we're taking a sample with something sharp inside the lung, that really does not lead to any meaningful leak in the lung. So maybe for a fraction of a second until that scab forms, to borrow the phrase. But the likelihood that there's one of those leaks is actually pretty low. Now, there may be slight differences between the likelihood of those leaks doing those biopsies from the outside in versus the inside out, so doing a CT-guided biopsy or a bronchoscopy. But again,
this is again air leaking into the chest wall, which can compress the lung.
Yeah, and to clarify that a little bit, not necessarily into the wall. If you think about your lung, to use the balloon analogy again, it's kind of like a water balloon that's inside another balloon. So it's very Inception like there, but it's a balloon that's wrapped in the lining of your chest, and your chest wall is just outside of it here. And the lungs themselves aren't actually pushing outwards to breathe. What causes you to breathe is that the muscles of your chest and right below your lungs, what's called your diaphragm, they kind of pull out first, and that pulls the lung to get bigger. And so it's what we call vacuum. So it's not that the air gets trapped in the wall of the chest, but it gets trapped in this little space that's in between your chest wall and your lung. And that's what we call pneumothorax, and that's just one of those leaks in the lung. The other potential risks that are associated with these procedures, bleeding. Anytime we take something into the body and try and take a sample, there's always a chance for bleeding. And nodules, if they're related to infection or cancer or inflammation, again, really the three biggest causes there, they can have blood vessels that are, blood vessels that are either growing, in a kind of chaotic way, just wherever they want to be growing, or they can be pretty fragile because they're inflamed. And so they can have a tendency to bleed a little bit more. And so now most of the time that's relatively minor bleeding. But sometimes it requires us to give some medicines either to the patient or down the tool that we're using to get the biopsies to nudge the bleeding to stop. And then the other, I mentioned that the lungs are kind of like an extension of your skin. They're kind of just your skin, but on the inside. The lungs are actually not a sterile place, even under the best of circumstances. There's just bacteria that kind of live here in very small amounts that aren't causing an infection, but just live there. And so anytime we do one of these procedures, there's always a small chance that we might take some of the bacteria from up here or here in the big parts of the lungs and carry them out to where the lung nodule is and cause a pneumonia or a lung infection. Now, the risks of those are pretty small. And again, they vary patient to patient to a degree. But, we're talking about, 1 in thousands for leaks in the lung, 1 in thousands to maybe slightly more common, depending on patients for bleeding, but a little bit more common for infection. But each of those, can be an important thing to consider when we're talking about, the timing of doing a lung biopsy and comparing it to the likelihood of something being a condition that we have to treat, be it cancer or otherwise.
Okay. And I want to get into Ashley's experience with your biopsy. But before we jump into that, as you're heading into a biopsy, what's the general likelihood that a given nodule is cancer?
So that, that really depends. I'm going to say it one more time that it depends, but it really depends on the area, that part of the United States that you're looking. Here in Tennessee, we have a lot of that fungus called histoplasma. So there are a lot of nodules that are not cancer. But if you go to another part of the country where some of those infections are less likely, the likelihood of cancer may be higher. So I will give a half answer there and just say that it depends. But it is high enough that anytime we see one of these nodules, one of the first questions we ask is, what is the likelihood that this could be cancer?
Would you say, I'm going to push a little bit, would you say that for people who don't have like a clearly malignant likely kind of nodule, for the things that we're monitoring, for the things that didn't trigger high risk, is the likelihood of cancer 50%? Is it much lower? What's a ballpark?
Much
Okay.
lower. So, a fair question. You'd be, especially if these are the low risk nodules, we're dealing with likelihoods of cancer single digits or less. So,
Hopefully you can reassure some folks who are
yes,
waiting for,
and
someone to
that's
reassure them.
why, to something you said earlier, Kyle, that again, based off those risk features, those characteristics of these nodules, that when we get to those, something that is far less than 50%, but if we get to something where the risk of cancer is just high enough based off the appearance of that nodule, those are the situations that we don't wait.
So Ashley, they didn't wait with you. How did they proceed? What was your procedure like?
I had both biopsies of the chest wall mass and the nodule in my lung at the same time. Different physicians did them. So I had multiple doctors in the room. They were CT guided biopsies. I was awake-ish. I don't know. I remember that the doctor who did the lung nodule biopsy was the one that breast cancer radiologist called to talk to, and she told her not to do the biopsy, and she told me that, and I responded, and then the nurse who was doing my anesthesia told me I can't talk, and I was like, but she said something to me. So it's definitely awake for part of it.
Hmm.
It was my first experience with Ativan, and it was lovely because it was high stress situation.
So we're having people
You know,
line up for biopsies of their lung nodules.
yeah, I'm
The
just being
Ativan dosing.
honest. I don't know how I would have
Yeah,
done that
please.
without it. Um, because it really calmed me down. Because I was very nervous, not about the procedure. I trusted everyone there, but about the results. And then I had
Sure.
to stay in the hospital, like recovery area. And then they did a CT of my chest to make sure that I didn't have a pneumothorax and that I could be discharged home. So I want to say I was spent almost a half a day be, be you know, the getting checked in, ready for the procedure, the actual procedure, and then the recovery. They made me wait for an hour before they got that CT of my chest. Or was it a chest x-ray? I don't know.
Oftentimes it's a chest X-ray afterwards, but
That's what it
it
was.
can
Yeah.
be different place to place.
No. It was as soon as I said that out loud. Yeah. So then I got an x-ray to make sure I didn't have a pneumothorax and could go home.
So they did the CT guided biopsy of your nodule. Do you, and you said you were awake for some of it. So it sounds like they were, they gave Ativan as they needed. And do you remember it being particularly painful? Like, what do you
No,
remember?
there was other medication they used too. I forget what it was that she gave me, but she said I would not be like completely asleep. And I don't I know I wasn't. I know I got in trouble for talking, which if you knew anything about me, sounds legit. Um so but it wasn't painful at all. I didn't feel anything. I had no pain after even or no bleeding or anything really. And I had two sites biopsied.
Okay. So they biopsied. Do you remember roughly how long it took to get a result as to whether it was or wasn't cancer?
Yes, absolutely. So I had the biopsy on a Monday and I got one of my results back on Wednesday, but I was rushed. They said that was not normal because of my age and everything. They want to present me to the cancer board at the institution that I was at, which is Freighter in Milwaukee. So I threw everyone for a loop because the chest wall mass was benign. But actually, when they called me with the results, it was again a very hard day. I found out I didn't have sarcoma, but they also told me the nodule was cancer. But they didn't know that it was lung cancer at that time because they weren't
Right.
staining it to look for lung cancer. They were staining it to look for sarcoma that had metastasized. I went into those biopsies thinking I had metastatic sarcoma. And I had not heard anyone say to me, you could have lung cancer at that point. And I'll also tell you, when I met with the physician and she went through, she did tell me some of the things that Alex was discussing about like what other things that nodule could be in my lung, like an infection. Um, but I mean, at the end of the day, I said, what do you think it is? And she said she thought it was a metastasis. Everything, looked like it was one thing until the biopsies came back. And then I waited. Then I had a very hard week where they were like restaining the biopsy in the lung to see what it was, but then they wanted me to get a PET scan and additional tests to make sure that they weren't missing another cancer. So I spent a lot of time that week getting tests at the hospital, and it took another week to get the call that you have lung cancer.
Yeah, I think what you're describing, that amount of time being in complete ambiguity, because the differences between what you find are dramatic in how your life is going to go.
Mhm.
And that timeline sounds pretty average to me.
Yeah.
It takes that to the person experiencing it takes forever. Um, and you had mentioned something that I think is interesting, where they see this nodule in your lung, they biopsy it, and they say, okay, it's cancer. It's probably from somewhere else, which is a weird thing if you're hearing this to say, like, you see a cancer there, you took a piece of it, and your first assumption is that it's not from the organ you found it in. And I think with cancers, a lot of them will spread to the lungs. So it is common And there are other areas in the body that do this too. The brain is similar. That if you see cancer there, you can't assume the cancer started there. And our nomenclature, the way we describe these things, is it is a cancer of the wherever it came from. So if it started in the colon, that would be colon cancer that went to the lung. Started in the liver, it would be liver cancer that went to the lung. So that's something that I think tripped me up in the beginning too, is if you have nodules in different areas, which is what they were looking for with the PET scan, you don't have multiple types of cancer. You have one type that's spread to different places. And it's really important to figure that out. And that's why they take that extra time, because the treatments are dramatically different. Getting into the scanning, Alex, question for you. You mentioned following up with CAT scans.
Mm-hmm.
Now, I think you know where I'm going. There's a lot of talk right now in the field about CAT scans versus PET scans. I know this comes up all the time for us. Can you speak a little bit to the difference of those things and how they might be useful with lung nodules?
Yeah, no, absolutely. So you can think of a CAT scan as telling you purely what the anatomy is, what the plumbing is. The PET scan is what we call a functional test, meaning it's telling us how, not only what the anatomy is, kind of what is where, but also, is it, what we call pretty active? We in many ways give a marker that we can see as brighter or less bright on those PET scans when something is growing quickly, and kind of like we talked about earlier, cancer just has, its mode is to grow. And so when we see that there's something that's not supposed to be there on the CT scan or PET scan, but and then is bright or active on the PET scan, then that can tell us, that is maybe more concerning, that could be a cancer. Now, one of the big differences is that PET scans are, generally speaking, can be of the entire body, and we use those PET scans, oftentimes when we are either on the fence about a nodule, and whether it is, it maybe has some of those high risk features, or it has maybe some features that are a little concerning, but not others. And we need that extra piece of information to say, is this growing actively, to decide, should we biopsy it now or not? Or we use them when we have, for example, in a case maybe similar to Ashley's, found out that something is cancer, and need to figure out, are there any spots other than where we found it that might be concerning? And because, if we are following a lung nodule, or we see a lung nodule, we might not need to get a picture of the belly or of the hip and the leg. But that changes if we know that something is cancer, because then there's that question of, what they told Ashley of, before they got the biopsy, we think that this is cancer that started one place and moved, and that you were mentioning, Kyle, of cancer being able to move in that way. It helps us answer the question of, are there any areas that we can find away from where we originally saw it, that are concerning for cancer, that we need to biopsy, or that we need to get a second look at? Importantly, and I hate to harp on this, it's just an eccentricity of my particular part of the world. The other thing that can grow quickly are infections, and so one of the reasons that we just don't start with a PET scan from the beginning, which might be one question, is that that might make us pick up a lot of things that show up as active, as that they're growing, but really are just little tiny pieces of infection that are maybe you know, trying to grow, but your immune system is knocking them back down, and actually, you know, would turn into nothing, and you wouldn't know that they're there. Um, and if we're, you know, when we're talking about risk and benefit, like you were talking about earlier, Kyle, that can, if we rely, potentially one of the arguments is that if we rely on that too heavily, too early, that it could lead to procedures that people don't need that carry risk. And so, generally speaking, we use PET scans kind of, you know, after the fact, if we found a cancer somewhere, or if we're really on the fence.
Okay. Yeah, that makes sense. So we run into the same challenge determining if something's tumor or if something's inflammation. And on PET scans, a lot of time we can't really tell for sure. So if those are two of your major things you're trying to rule out, I could see how the PET scan would muddy the waters. Um, Back to Ashley, you got your biopsy and then it was determined to be a cancer. They said, started in the lung, looks like it stayed in the lung. What happened next?
I was referred to a thoracic surgeon to schedule a lobectomy. Because of the size of my nodule, the standard of care was to remove the lobe where the nodule was. Mine was the left lower lobe.
Okay. So yeah, and it sounds like you had a fairly small tumor that they felt like they could get it all out with that surgery. How did the surgery go?
Well, I did seek out a second opinion, which I just want to say I'm very passionate about that. I seemed like standard of care. It looked like standard of care. I felt like I should still talk to someone else. So I did meet with another thoracic surgeon at the University of Wisconsin who said she would do the same procedure. So I decided to stay at Milwaukee because it was close. I had my lobectomy in October, and in addition to removing that left lobe, they also removed the chest wall mass, which was on my right side. So I had that procedure as well. So the surgery was a little longer because it was like the two surgeries and they were on separate sides. Um, it was pretty hard recovery and also a lot of surprises along the way. I thought I was going to have like all this difficulty. I'm a very active person. I have two small children, 4 and 5. And I was really just worried. I have um, I have three levels, 2 flights of stairs. I thought I had all these ideas in my head because they said I would lose 30% of my lung capacity, that it would be something I would notice all the time, but I really didn't. I mean, I had trouble getting around, of course, after the surgery because I was in pain. But once that initial pain subsided, like I would say the first week post-op was really hard. I was just
Due
in
to pain?
constant pain. Yeah, I was in so much pain and I could not sleep.
And was
I'm
that
still
pain like
very,
at the surgery site, or describe what you were feeling?
definitely the surgery site. I had 6 incisions. I had
Hmm.
an incision from my chest tube, 3 small incisions from the robotic part of the surgery, a larger incision to remove the lobe, and then a large incision by the chest wall mass. I, yeah, I was on a lot of medications like muscle relaxants, pain medications, lidocaine patches, but it was just so uncomfortable. But I mean, it was once I got out of that, things got easy quickly. I was up and walking within I mean, like a mile. Like I was walking like a mile, probably, I want to say like maybe a week and a half after surgery. So they really were very encouraging of me walking because they said that was the best way to just get the lungs back right away. So I had this barometer when I wasn't walking as a way to exercise my lung, that little breathing tube machine thing. My kids loved it.
Yeah. We had
They
one
were
around
like,
when I was a kid. My brother had one. He was sick, and we would always play with it.
yeah, they were like, Mom,
Yeah.
go. harder, you can get the ball to go up
Yeah.
further. It was really kind of actually cute. But yeah, and I would say too, like, if I didn't have a recliner, like, I don't know how I would have slept that first week.
Hmm.
No one told me that except a nurse who called me for my insurance because I didn't own a recliner and I borrowed someone's. I'm so glad because it just was impossible to sleep. But like I said, once I got back to that, there were a lot of surprises about my recovery. And I had a persistent cough for a long time, but no one was worried about it. They said it was just normal because my lungs were now going into like a space. I'm sure I'm messing this up, Alex, but
No.
something about that like upper lobe was like uncomfortable with the new space that it had or something. So, and I still get a cough. I'm 6 months post-op. I'm totally fine all day long. And when I lay down and have like position changes, I'll still cough a little. But other than that, like I'm back to exercise 4 days a week. And I'm back to lifting the same weights I was lifting before surgery. So I feel very lucky about how quickly my activity has returned.
That's that's great. And it sounds like you're kind of approaching the light at the end of the tunnel there, if not there already. For a lot of people who are worried that it's cancer, uh, they have an idea or they're curious or worried about what that's going to mean long term. Did you get therapy? Did you get systemic therapy, meaning things that go everywhere in the body, like chemotherapy, pills? What other things did you require?
Nothing. No, I'm so lucky. I'm one of 16% of lung cancer patients who get their diagnosis before it's advanced. I just got, I, I really feel like I got so lucky that I had this chest wall mass. I mean, that, and I credit myself because I do, because like, I didn't even talk about when I went to my primary care and she said I could just go to a dermatologist. She thought it was a lipoma. I could just get it out. It's not that that mass ended up being benign, but for some reason, I was very persistent about who I was going to like have make that call. Um, so I I would just encourage anyone who's worried about a nodule and their doctor is telling them, you know, we don't need to biopsy this yet. We can wait. If you feel uncomfortable, I would get a second opinion. And I feel like most good physicians are very encouraging of that. I got a second opinion with my thoracic oncologist as well because I just wanted to talk to a different doctor and just hear. I wasn't even referred to an oncologist because the standard of care is lobectomy and then monitor with scans. But I wanted to speak to an oncologist, so that was considered a second opinion. I met with my oncologist at Freighter, and then once I got my gene mutation testing back, I met with an expert for the ROS1 mutation that I had. So I'm like the most encouraging person of if you don't like what you're hearing, just go talk to someone else. Not to give you a different answer. Like every step of the way, the doctors were very consistent. There was some minor tweaks. Like one surgeon wasn't going to remove the chest wall mass, didn't like the idea of doing both procedures, but one surgeon was comfortable with it. So it just empowers you to have like more conversations.
Yeah. Alex, how would you feel if someone was asking for a second opinion based on your recommendations?
I'm fine with that. I'm fine with that. I often say, we are the captain of our own ship, and we have to we're responsible for keeping that ship afloat, ultimately. And so, being confident in your decisions, being confident that you are operating under the best advice that you can get is always advisable. And ultimately, as a physician, as much as anything else, we're an advisor to patients, and so getting all the advice that you can is good, and making sure it's consistent.
Yeah, I couldn't agree more. I completely endorse second opinions. Most people are not upset in any way about that. Ashley, as the patient, you're the one that has to bear the burdens of whatever the plan is. So, you are beholden to yourself and yourself primarily. So whatever's best for you, your medical team has to support and rally around that. One thing I want to touch on before we call time is something that's coming out in the field, which is all these new testing to identify cancers early. And I'll say from an oncologist perspective, we acknowledge this is a very young field. Uh, these tools haven't been around for a while, and we're still learning how to best use them. Alex, I'm curious if these, usually it's probably going to be blood tests, but let me know if other things come to mind that claim they're able to diagnose things early or will they able to identify tumor DNA or something like that. Have any of these tests come across your practice? And if so, what are your thoughts?
Yeah, I think that's it, as you said, it is a growing area, rapidly growing area. I would say that we hear about them, we talk about them periodically. Um, it is always a question of, in my mind, of context, because some of these or all of these tests are done in the context of the individual person and have a likelihood of they can be very, very sensitive tests, meaning they if there's a shred of DNA anywhere, they'll find them and identify it. But it may be that it's not, that it's that you're finding it before it's turned into a problem and before it would turn into a problem. And so that one of the areas that as an oncologist, you I'm sure are more savvy than I, but they're looking at is saying how much is enough to see in the blood, how much is enough to see in this particular sample to say with some degree of certainty or reliability that what we think this is concerning enough that we can you know, move forward, say, in a nodule that you found that was maybe in between, and use that as that additional data point to say, what, it's concerning. This test is positive. I think that this is actually something. We should get a sample of it. So, I'd say that frequently the place that I see this is when we've identified or, for example, there's a cancer, a spot that's moved to the bone, and we try and take a sample of that, or wherever that nodule may be outside of the lung, and we get a diagnosis of cancer, but not the whole picture. We don't get enough to run all of those in-depth tests that we wish we could run. And so sometimes we send some additional blood tests to see if we can get enough of that DNA, those markers, to say whether or not some treatments may be helpful or not helpful. So I haven't, operationalized many of those blood tests yet, but it's really exciting seeing how quickly it's growing, how quickly they're getting validated. And an area that we rely heavily on our superb oncologists such as yourself to help us advance that field of knowledge.
Yeah, I couldn't agree more. I think it's tough because they're very sensitive, and there's a lot of areas in the body that can make things that have mutations that look like cancer, and your body turns over small cancers all the time. And there is still this phenomena that if things are really, really small, it might be controlled by the immune system, and who knows if it would ever turn into a problem. One example of this is prostate cancer, which many people develop prostate cancer that we just follow. We don't need to treat it because it's so low risk. So I think in the absence of a pulmonary nodule or something, we have to be really careful about how we use these tests. And I don't typically recommend that the average individual gets these tests to just look to see if there's evidence of tumor in their blood. Because then what do you do with that? Let's say you scan the whole body and you don't see anything. Now you're like, okay, well, I've got cancer somewhere probably, and like go enjoy your day. That's a tough thing to navigate. But I do think for folks who have lung nodules that we don't exactly know if they're cancer yet, we're not necessarily going to go in and biopsy right now. Or maybe even if you do biopsy, as some additional information, I think they're going to be coming to the forefront, although right now I don't believe it's standard of care. But I bet we're getting there. I think this is something to look out for on the horizon. Before we wrap up, Ashley, any last words of wisdom or advice for patients who are worried about their own lung nodules?
My advice is always just to be informed and advocate for yourself, whether that's through a second opinion or, I actually do not Google or do any of my own like medical research. I'll read guidelines because if someone tells me there's a guideline on it, but I don't go to the internet for advice. So much that when I woke up from my lobectomy, I didn't realize that they were taking my lung from the back. I thought I was going to have incisions in the front. So I trust the medical professionals to be the experts in the care. I just advocate for myself along the way. And that's what I would encourage any patient to do as well.
That sounds great. Couldn't say anything better for myself. Alex, any last words for the person who is concerned, has a lung nodule, not sure how to feel?
Well, I think the big one is certainly to echo what Ashley said about knowing, to ask around and be comfortable in the information that you receive, and the decision you make going forward of how best to keep eyes on this yourself. But also just, this is it is not when we see these nodules, it's not a guarantee that it's cancer. It is a moment that it can be very frightening whenever we see something like that, especially in the current age where we get these answers so quickly, these reports so quickly. But that's a moment where I'd encourage you to breathe and have the space to say, this is something that we need to answer, but this is not a diagnosis. This is a symptom.
Great, well put. And with that, I think we'll cut it. Thank you, everyone, for listening. Again, this is Cracking Cancer. You can subscribe, and visit crackingcancer.org to learn how to support the mission. Let us know what are the things you want to hear about, and we'll get after it. Thank you both for joining us.
Thanks
for having me.
All right, bye, everyone. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.